Yes, sir. Yes, sir. Yes, sir.
Can we restart, Dr.
Yeah,
Sanjay?
yes, sir. Yes, sir. You
Yeah.
can start, sir.
Okay. Thank you.
Mute everybody.
So should I start?
Yes, please.
Right. So thank you very much for this invitation, and I'm going to talk on this subject of atrial fibrillation and heart failure as a part of the series of arrhythmias in heart failure population. So um, as we were alluding to this particular statement from Dr. Eugene Brown-Wall in 1997 when he was giving this memorial lecture in which he talked about how atrial fibrillation and heart failure are the two new epidemics of cardiovascular disease. And 25 years later, I think the statement that he made in 1997 still holds true. What we know is that both AF and heart failure have substantial implications for economic costs because they affect a lot of patients. And in those patients, they obviously have implications for morbidity and, more importantly, mortality. These two diseases share the patient population. They tend to happen disproportionately more in the older patients. And the observations for the last 2 to 3 decades is that the incidence of each of these entities is doubling for every successive decade of increase in age. So as the global population gets older, it can be anticipated that we're going to be seeing a lot of atrial fibrillation and heart failure. And it is also not totally surprising that these two conditions coexist with an annual incidence of 2 to 5% and overall prevalence that can be as high as 40% in some of the populations. And one of the most famous population studies, which is the Framingham Heart Study that is ongoing, but it started actually following patients in the 1950s, has shown in these two sets of graphs that I'm depicting here. On the left is the cumulative incidence of congestive heart failure over time, and on the right is the cumulative incidence of atrial fibrillation over time in the Framingham population. And you can see that these two curves are nearly identical, showing how these two diseases tend to have a more or less similar footprint, and they often coexist. So the fact that atrial fibrillation and heart failure coexist should not be surprising. These diseases perpetuate each other. So if you think about atrial fibrillation and how it can cause heart failure, probably the most likely explanation is the ventricular rate control, which does not seem to be very good, especially in the early period of AF. And that, together with the irregular filling and emptying period, can lead to chamber dilatation and the onset of systolic dysfunction. And once that process starts, the lack of atrial kick with persistent atrial fibrillation further aggravates this by decreasing the cardiac output. And of course, there are other phenomena that are probably not as well recognized or as easily identified, and those could be low-grade ischemia, energy depletion due to the irregular and fast rates, and of course, alterations in calcium regulation that can all affect myocardial contractility. Similarly, heart failure can perpetuate AF in the long run. Uh, it's very well known that heart failure patients, whether it's systolic or diastolic, tend to have elevated cardiac filling pressures. And as a result of that, there is atrial dilatation. And within the atria, there are stretch receptors which can actually alter the action potential dynamics. And just that alone can be a proarrhythmic phenomenon. In the long run, though, with persistent atrial dilatation, these patients can develop atrial fibrosis and regional conduction abnormalities, and then that becomes a more established substrate for the development of atrial fibrillation. And of course, some of the autonomic and neuroendocrine dysfunction that is associated with heart failure can also be proarrhythmic. So, without a doubt, both these conditions can promote each other. So the fact that AF happens in the heart failure patients is not a surprise. However, the recognition of AF in this patient population is important because it is now well recognized that the development of AF in heart failure patients actually can have mortality implications. So the Framingham study that I keep going back to, because it's one of those studies where the patients have been followed very closely. It's a cohort that gives us about 40, 50 years worth of data. And in that, if you look at the impact of comorbid conditions, a time-dependent variable, the development of AF in heart failure patients can increase their mortality risk independently several-fold. And that association seems to be even stronger in women than men. And this is not an isolated finding. Several of the heart failure studies that we are all familiar with that were done primarily to test the efficacy of different treatment modalities in heart failure patients have also shown this association between atrial fibrillation and higher mortality in the heart failure population. And along those lines, this particular study is especially interesting because this again is a population study that looked at 21 years worth of data in the Olmsted County, which is a predominantly Caucasian population in the surrounding areas of the Mayo Clinic. And what these investigators found is that when you look at mortality after the diagnosis of AF, it continues to be high. But what was remarkable about the findings was that after the diagnosis of AF in the heart failure population, if you break it down based on early, which is the first 4 months from the diagnosis of AF, versus long-term AF follow-up in these patients, the early period after AF is recognized seems to have the highest mortality. And that actually can be explained because when folks develop AF, when it's not recognized, that's the time when the ventricular rates are relatively fast. That's also the time when, if interventions are done, particularly antiarrhythmic drugs, that the side effects of those medications become more manifest. But nevertheless, the fact that atrial fibrillation increases mortality certainly brings this important concern that the management of atrial fibrillation in the heart failure population should be more aggressive than what you might otherwise consider. And so the expectation is that if atrial fibrillation indeed increases mortality in the heart failure population, restoring and maintaining sinus rhythm ought to correct that. So the hypothesis is certainly sound. However, when you look at the data that's out there, it doesn't quite bear out the way we would have thought. So this particular study that I'm citing here, the AFIRM trial, is probably one of the best known studies that recruited over 4,000 patients who were randomized to either rhythm control using antiarrhythmic drugs or medical rate control. And this was not a study that was done on the heart failure population. In fact, only 9% of the participating patients in this study had structural heart disease. Nevertheless, over a 5-year period, what was clear is that the primary endpoint of mortality was not different between patients who were randomized to the rhythm control versus rate control arm. And if you look at the graph and the trends and the curves, if anything, mortality was higher in patients who were randomized to the rhythm control arm. So this was the first study that really gave pause to the argument that atrial fibrillation patients will benefit from restoration and maintenance of sinus rhythm. And following AFIRM, there have been numerous studies that have actually been designed along these lines, and I'm just listing the acronym of some of these here, and they have all shown similar results. And in that context, the study in red, the AF-CHF trial, recruited over 1,000 patients. It was an exclusive population of heart failure patients who were randomized to medical rate control versus rhythm control with antiarrhythmic drug. And once again, what was observed in the AFIRM study also bore out in the AF-CHF trial. So based on these multiple prospective randomized studies, the cumulative data would suggest that the benefit of restoring sinus rhythm in AF patients, while it may help them feel a little bit better when it comes to mortality, this does not do much more beyond medical rate control. And so while the study data would support that conclusion, I think we have to be cautious in interpreting these data. And the reasons are several, but some of the important ones I've tried to highlight here. So when you really dive deep into the data from all of these studies and you look at, what really happened to these patients. So yes, it's one thing to assign patient to a particular arm, but it's another thing to really understand how efficacious that arm was. So for the AFIRM trial, when you look at how many patients that were randomized to the rhythm control arm actually maintained sinus rhythm, that was only 23% of those patients. So just because you're randomized to the arm doesn't mean that you are in sinus rhythm. So that's why that presumption may be erroneous. Another thing to keep in mind is that when patients were participating in these studies, the modality that was used to document presence of sinus rhythm were mostly office ECGs and maybe an occasional 24 to 48 hour Holter. And we know this well now that in patients with paroxysmal AF, those modalities, an office ECG or a 24-hour, 48-hour Holter is not sufficient to capture the true AF burden. So it is quite possible that even though the patient showed up in sinus rhythm in the office, they actually were having a lot more AF. So the presumption that they were in sinus rhythm consistently may not be correct. And then, of course, there is the final concern which all of us share, and that is the mortality side effect that a lot of these antiarrhythmic drugs have. And that has been shown repeatedly in a variety of trials, including the AFIRM study, that antiarrhythmic drugs can kill. So the fact that patients who were randomized to rhythm control in all these studies using antiarrhythmic drug therapy, they did not do well, should not be such a surprise. The obvious question then is there a way to overcome this limitation of trying to achieve rhythm control using antiarrhythmic drugs? And catheter ablation, which is now perhaps the most popular strategy, at least in the United States, for managing patients with atrial fibrillation, and it's being used widely world over, can it overcome these limitations? So the answer to that is yes, and I'm going to show you some data to support that. So the benefit of catheter ablation over antiarrhythmic drug therapy in patients with atrial fibrillation has been reproducibly documented. One of the early trials to actually look at this prospectively was this relatively small study, 70 patients with paroxysmal AF of at least 3 months duration who were randomized to either go directly for catheter ablation versus antiarrhythmic drugs. And mind you, nowadays that may sound like not such a compelling study design, but we are talking about 2005 when catheter ablation was just being offered, and the modalities for delivering energy and ablating were not quite as good as what we have now. But even in that relatively primitive era of catheter ablation, it was pretty clear that over a 1-year follow-up, patients who underwent catheter ablation did significantly better than patients who were maintained on antiarrhythmic drugs. And fast forward now to 2020, there have been numerous trials that have made this comparison. And the data now consistently shows that the single procedure efficacy of catheter ablation in patients with paroxysmal AF is about 75 to 80%. And the efficacy of this modality is a little bit less in patients with non-paroxysmal AF, where single procedure success is about 60 to 65%. And in both of these situations, catheter ablation is at least twice as effective as antiarrhythmic drug therapy. So now, with that background, let's think about what is the typical profile of a patient with congestive heart failure who presents in AF. So as we've talked earlier, patients with heart failure tend to be older as opposed to a standard patient with paroxysmal AF. Also, the duration of AF in the heart failure population may be longer. The heart failure population certainly has a lot of comorbidities. And the nature of atrial fibrillation in the heart failure population is more likely to be non-paroxysmal. And it is not uncommon that together with ventricular dysfunction, these patients also have evidence for atrial fibrosis. So the substrate and the mechanisms underlying atrial fibrillation in the heart failure population may be somewhat different than what you would expect in a traditional paroxysmal AF patient. And so the obvious question is, can we have the same expectations for the success of AF ablation in an exclusive population of patients with congestive heart failure? And this is an important question, and it has actually been looked at for the last several years. So one of the earliest groups to try to assess the performance of catheter ablation in congestive heart failure population was the Bordeaux group. And this is the group that actually described AF ablation originally in 1998. And in this study in 2004, they reported their observations in heart failure patients. So they did a randomization of over 100 patients, half of whom had low EF with an ejection fraction of 45% or less, and clinical congestive heart failure. And they had a control population of 58 patients who had structurally normal heart. And both of these patients underwent catheter ablation. The patients were followed for about a year after the procedure. So the first thing that is important to note in this study is that the long-term maintenance of sinus rhythm was comparable between patients who had structurally normal hearts versus patients who had abnormal EFs and congestive heart failure. And then some of the observations related to maintenance of sinus rhythm in the heart failure population were, first and foremost, there was a significant improvement in the cardiac remodeling, so that these patients demonstrated improvement in the ejection fraction, as well as the end systolic and the end diastolic chamber dimensions. Another very important observation from the study was that the patients who had congestive heart failure, they had both secondary causes for structural heart disease as well as idiopathic dilated cardiomyopathy. And the improvement in ejection fraction was seen regardless of the underlying cause of the cardiomyopathy. So even patients who have ischemic cardiomyopathy and well-established scars may have a component of tachycardia-mediated cardiomyopathy, which restoration and maintenance of sinus rhythm can actually address. So these observations that were made by the Hazegera group in 2004 have been replicated by many other centers, including our own experience that we published a few years back. But the question that this study and all of those small studies did not answer is whether the improvement in the cardiac remodeling after catheter ablation in the heart failure population actually translates into mortality benefits. And to answer this question, the study that I'm showing you here, the CASTLE AF trial, which was recently published in the New England Journal of Medicine, I think is an important study which actually addresses this question. So these investigators conducted a multi-center study in which over 3,000 patients were approached, and based on the sample size estimates, over 350 patients comprised the final cohort, and they were distributed equally between catheter ablation of atrial fibrillation versus medical rate control. Now, the investigators designed the study specifically to address one of the most common endpoints that is looked for in the heart failure population, and that is the combined endpoint of mortality and heart failure related hospitalizations. And what they found is that over a follow-up extending out to 5 years, patients randomized to ablation therapy had a significantly better primary endpoint of death or hospitalization from worsening heart failure. They also looked at mortality as a secondary endpoint alone. And once again, they found that patients randomized to ablation therapy actually had a significant improvement in mortality versus medical rate control. So this study, I think, is the trial that we were all looking for to provide us guidance on how to tackle atrial fibrillation in the heart failure population. And these data, together with all the cumulative experience that we have put together through smaller studies over the last 15 years, I think provide us now enough impetus to consider atrial fibrillation ablation in our heart failure population that develops AF. Having said that, one of the things that was seen in CASTLE AF was that despite significant improvement in mortality between the two groups, when you actually looked at how much AF ablation contributed to improvement in ejection fraction from baseline, the improvement in EF was somewhat modest, about 8%. And so a question that remained unanswered in this trial was whether there is a better way to identify heart failure patients that may derive the most benefit from catheter ablation. And so to address this question, there is another study, the Camera MRI trial, which was published around the same time as CASTLE AF in JACC. And this is a smaller study which actually recruited only about 60 patients. But the point of the study was that the population of patients that they recruited were true idiopathic cardiomyopathy heart failure patients with atrial fibrillation. So they excluded any patient who had a secondary cause for the cardiomyopathy. And then they further tried to look at these idiopathic patients by using cardiac MRI to identify delayed enhancement abnormalities, with the thought being that if in idiopathic cardiomyopathy population there is the presence of delayed enhancement on MRI, that implies the presence of fibrosis, which suggests that there may be more permanent damage, versus the lack of fibrosis together with LV dysfunction probably shows a true tachycardia-mediated cardiomyopathy population. So what the investigators found, consistent with what had been shown now in many trials, is that patients randomized to catheter ablation did significantly better in terms of the improvement of LV function versus medical rate control, where the improvement was 4% versus about 18% from baseline. The interesting thing about this particular study was that when you looked at the subgroup of patients who had baseline manifested delayed enhancement abnormalities versus those patients who were lacking delayed enhancement abnormalities, the ones without delayed enhancement abnormalities on cardiac MRI showed the most dramatic improvement in the EF. So the original Camera MRI study had just a 6-month follow-up, and these investigators have now put together the more extended follow-up of the original cohort, which they just published in JACC EP. And this is now extending the follow-up out to 4 years. And once again, the original observation of improvement in LV function at baseline continued to be significantly better in the catheter ablation arm. And the benefit of cardiac MRI in identifying LGE positive versus negative patients and its implications on improvement in LV function continued to hold true over this extended follow-up for 4 years, so that patients who lacked LGE on the cardiac MRI that was done at baseline showed the most improvement that was seen at 6 months and also out at 4 years. So I think this study gives us a little bit more insight into the patient population that may derive the most benefit from restoration and maintenance of sinus rhythm with catheter ablation in the heart failure population. So to summarize the talk, as I showed you earlier, the two conditions, atrial fibrillation and heart failure, they frequently coexist. It's not a surprise because it's a lot of shared pathology between these two diseases. The development of atrial fibrillation in heart failure population has significant implications for mortality. This has been shown over and over again. But to restore sinus rhythm and try to maintain sinus rhythm using antiarrhythmic drug therapy in these patients has not been shown to improve long-term mortality beyond good rate control. And that is where I think catheter ablation is an intervention that people should start considering more and early in the disease process, because now we have ample data that supports the benefit of catheter ablation, both for improving LV function, but also more recently through the CASTLE AF trial, it actually has been found to improve mortality in this population. Obviously, there are some unresolved issues around catheter ablation, and those include the kind of ablation strategy that may benefit heart failure patients to improve single procedure efficacy. And of course, through the camera MRI study, we have some insights into the best patient who would benefit from catheter ablation. But regardless of these minor unresolved issues that the EP community continues to work towards, the most recent update on the guidelines for catheter ablation, which was published in 2017, specifically mentions catheter ablation to be considered as a 2A indication, which is primary catheter ablation as the first treatment option, both for patients with paroxysmal and persistent AF. And the guidelines specifically had the statement that it is reasonable to use similar indications for AF ablation in selected patients with heart failure as for patients without heart failure, which means offering catheter ablation to heart failure patients is now considered a class 2A indication, with the level of evidence in some instances as high as B. And so that's what I want to leave the audience, the final slide, to remember that the guidelines have moved, and these days catheter ablation is being offered increasingly to the heart failure patients. And my suggestion would be to consider it earlier in the onset of AF in this patient population. So I think I'm going to stop here. I want to thank everyone who is attending. I want to thank the panel here for allowing me to join this discussion.
Ajit, I think we'll have the questions after Balbir's talk also. Ajit?
Yeah, thank you, Dr. Sanjay, for that excellent talk. You outlined the indications of AF and heart failure, and what contributes to the outcomes in AF management and with heart failure. I think the next talk is by Dr. Balbir Singh. Dr. Balbir Singh, as most of you know, is a versatile cardiologist. He basically takes care of both interventional cardiology and interventional electrophysiology. And we have no better person other than Dr. Balbir to talk on device therapy in heart failure. Over to you, Balbir.
Thanks, Ajit and Narsimhan, and it's a pleasure to be here. I thank Hari Krishnan, Dr. Chopra for giving me this opportunity here. I'm going to speak on CRT in heart failure because a lot has been written. There's a lot of controversial things, and heart failure specialists are very confused which patient should have a CRT. And let's put a rest to all these confusions through this CRT lecture. So it was in 1925 when first actually the concept of dyssynchrony was understood. And this is a very beautiful paper which brings out that electrical stimulation of the ventricle, how it produced dyssynchrony of the left ventricle. And we now still realize how dyssynchrony is produced and how we can help dyssynchrony. So a CRT basically has two leads, the left ventricle lead, the right ventricle lead, and the sensing happens in the atria, sensing or pacing happens in the atria. This is a defibrillator coil, so this is a CRTD device. This is all what we are going to discuss today. This was the first of these trials. So you can imagine that we have 20 years of CRT data now available to us. This was the Mastic Trial, which is published in 2001. This is a French trial. And this is what it was. 320 patients were implanted the device. The device was, at this point in time, put in an off mode. After a period of 1 month, in half the patient, the device was put on, and in a half, it was put off. So in the patients where it was put on, the 6-minute walk test was conducted, and then you saw this in those it was on, the 6-minute walk test improved. In those it was put off, it kept deteriorating, and then this was changed. In the phase 1, those who were on were put off, and those who were off were put on, and you had the curves diverging once and again. This was a clear concept proof that in selected patients, you could actually improve the 6-minute walk test, and you can't have a better proof of an experiment even though with a small number of patients, and 3 months follow-up, it was a clear indication that the quality of life scores are going to improve with CRT. And the inclusion criteria in this study were very simple: QRS more than 120 milliseconds, and now we have debated a lot of those criteria. So this was 2001. Over the period of time, we have had several studies. You can see a lot of them listed here. Some started showing mortality benefits. So what more does one have to show to a heart failure patient a mortality benefit? Quality of life and NYHA class improvement was established after those few initial trials. But the other thing that it started improving was the ejection fraction. So things that now clearly many trials showed: the mortality benefit and improvement in ejection fraction and the remodeling of the ventricle. Now, this is a very elegant diagram. Echo was not in the vogue for many years to come. There were a lot of controversy about echo data, but this is a very elegant diagram. So in this normal conduction, you have these all going down. This is a strain pattern, a global strain. And when you have left bundle branch block, you have some parts going up, some parts going down. So this change from hair to hair happens, and this suggests a dysynchrony. After 20 years, can there be still questions? And yes, there are too many questions. The first thing that came from the reverse trial was that there is increased survival and there is remodeling of the ventricle. But the paradigm also showed improved mortality and remodeling of the ventricle. So the maximum dose of sacubitril/valsartan combination resulted in ejection fraction improvement by 7.5%. So I'm questioned by my heart failure experts: is that patient who has LBB, does he need a CRT if you can solve this problem with ARNI without putting in a device? Now the same trial, the Paradigm HF, has patients who had LBB. These are the patients on the lower two curves who had LBB, and this is the patient who has the QRS less than 120. It's not just LBB, it is QRS more than 120. So the QRS more than 120, the improvement ejection fraction was much lower than those who had normal QRS. But those who had a CRT, even though they had a sacubitril/valsartan combination, their improvement in ejection fraction was more than those who did not have a CRT, clearly indicating that just sacubitril/valsartan is not the answer for those who have a QRS more than 120. You have to add on a CRT in this group of patients because you want more improvement in ejection fraction. So this is one part which is clearly settled, that if the QRS is more, just valsartan sacubitril is not enough. The second issue is that 1/3 of the patients do not experience the full benefit of CRT. So this is, you can see multiple trials and showing that it just closes at about 70% benefit, 30% do not benefit. So the definition of benefit can also be very different. Some people can say symptomatic improvement, others where in these studies has been end systolic volume or ejection fraction improvement by more than 10 to 15%. So that's a more robust criteria, and this data is on that end systolic volumes. So it is dependent on multiple factors. Left bundle branch block does better than right bundle branch block. QRS more than 150 does better than less than 150. Transmural scar, LV contractile reserve, mitral regurgitation. Females do much better than men. Non-ischemic cardiomyopathy does better than ischemic. Some biomarkers can help. So what is this going on? Why are there so many factors which affect the CRT response? So we must select the appropriate patient, which I'm going to show you what is an appropriate patient. The implant site has to be done very carefully. We are very careful in choosing the implant site. If it is not clear, if you're not happy, we have many other options. So implant position of the lead is very important in the therapy. Optimal programming, which I'm also going to show you, is an important thing. And then we need heart failure specialists to manage the patient thereafter. So patient selection is the first thing. QRS, I said, more than 150, excellent. Morphology, LVBP, etiology, non-ischemic, all these are pointers of excellent response. LV scar, and where is the scar located? What about severe MR, which many patients have? So what about patients who have a QRS between 120 and 150? So this is a small study. If the QRS is more than 150, you see the response of the LV's volumes and the ejection fraction is much more than those who have 120 to 150. But that doesn't mean that 120 to 150 should go. So this is what I showed you earlier, a circumferential strain pattern baseline and with CRT change completely. The pattern changes completely. We have even seen much better responses than this one. Suboptimal position, you place the lead in the apex or in the scar, you're bound to have problems. So we draw a circle and we know which are the places which we want to go to, anterior, lateral, or posterior. We don't want to go to anteroseptal. We don't want to go anterior interventricular vein. We don't want to go to the middle cardiac veins. We don't want to go to the apex. We want to go to the base. So lead position is an important concept. Now, this is what I said about QRS. So we know that QRS matters. We know the lead position matters. And we know that you can select the lead position based on the circumferential strain pattern. We don't do that because it's very cumbersome in the lab. We do it by measuring the QLV interval, which also is a good guide to the delay that happens in the lead. But this is one way of checking which lead position is going to be of benefit. When we program these patients, loss of LV or BIV pacing is very important. Programming is extremely important in these patients. Medications, natural progression of disease, and heart failure clinics. So this is another important thing what one must learn. If the pacing is BIV pacing is more than 98.4%, you get much better response than if it is less than 98.5. So this is a very clear indication that you should try to achieve as high as BIV pacing as possible. Now, this is not known to many people, and this is one of the major concepts. So there is two kinds of pacing. Quantitatively, the programmer may show that you are having good 99% BIV pacing, but when you look at the ECGs, you sometimes realize that patient is having fusion, and sometimes it's not pacing properly intermittently because of the thresholds having gone up. So thresholds going up, atrial fibrillation, PVCs, competitive AV nodal conduction are some of the very important reasons which inhibit the BIV pacing. Let's look at an example. This is a patient who has AF, has intermittent BIV pacing and intermittent broad QRS, and you ablate and you get him back to CRT pacing. So as we said, ablation is very important for heart failure here. Here, if you have a long-standing persistent atrial fibrillation, you would just do an AV nodal ablation and help the patient. So we know suboptimal medical management is also associated with loss of patient improvement. Now, let's go on to what we need to do in non-responders. We need to go back and look at the complete patient assessment. We will go back to the programmer, look at lead positions, and manage it. The next question that comes, which I am very, very sure about, that there's a group of patients who are so-called mid-range ejection fraction. This is a review by Milton Packer, who says heart failure with mid-range ejection fraction, a disorder that a psychiatrist would love. He feels that there is nothing as mid-range ejection fraction. These people will go on to have lower ejection fraction as time passes. So if somebody has a left bundle branch block and the ejection fraction between 40 and 45%, I'm very keen to intervene early in the disease because you are going to make them much better on the long term. And this is concept has been brought out very clearly that ejection fraction per se is not the answer. It's easy to measure, very attractive, but not a great thing to follow. What is most important is end systolic volume. And now in our clinics, end systolic volume is the most important parameter. You can see as the end systolic volume goes up, you get much lesser years to live as compared to those who have end systolic volume less than 95. And the response rate is also calculated based on these. So we have a sweet spot, which is going on as NYHA class 2 to 3, ejection fraction 26 to 35%. Clearly, we'll have this group 35 to 40%, class 1, left bundle branch block, QRS more than 150, who are likely to remodel and may not progress into heart failure over a long period of time. So the most problem is that the most eligible people do not receive CRT. This is a study which is the Improve HF registry with more than 15,000 patients. NYHA class QRS was not collected by the physician in almost half of the patients. 9% were only found eligible, And in more than half of these 9%, the device was not implanted. So based on the guidelines, we know QRS more than 150, left bundle branch block, class 1A, QRS between 130 to 190, 149, LBB, class 1B. Non-LBB QRS has to be more than 150, and 2A, 130 to 149 non-LBB is class 2B. So what is more important? Is the width or the bundle more important? So for me, the bundle is more important. If you have a patient who has QRS 130 and has a left bundle branch block, he will benefit. But if he has non-LBB, QRS is 140, 150, he may not respond as well as 130 LBB does. This is borne out by many studies, and we know LBB is the biggest predictor of benefit. And remember, the definition of LBB is by the Strauss criteria. I'm not going to repeat it, but we must memorize that criteria because that's what is going to matter in the clinics. RAFT study similarly showed LBB benefit much more than others. So did MADRID CRT. So we have very good data to show the bundle is more important than the QRS duration, and clearly it is the width and the bundle which both can help. Now, if I get a female non-ischemic cardiomyopathy, left bundle branch block, I tell them that you have a chance of more than 90% of benefit. And females have much better survival from CRT than men. So whatever the reasons may be, we know multiple studies showing the same thing. Etiology, non-ischemic cardiomyopathy is more common in women. QRS is generally left bundle branch block in women. They generally have smaller cardiac size, and smaller height and weight puts them at a much more benefit. So if we look at the therapies, sacubitril, valsartan has not been put into this. If you have an ACE inhibitor, ARB is minus 38% benefit. If you add beta blockers, minus 77. If you add a device, CRT or an ICD, the benefit is going to be minus 90. So they add on to an incremental benefit. So this is what is important. But we must also look at many indicated patients are not planned for CRT, and patient refusal and cost are very common in our country. Let's look at another aspect, which is physiological pacing, because this is another important aspect. This patient has got a pacemaker, her ejection fraction is 40%, and she now comes with heart failure symptoms with an NT-proBNP, which is elevated, and systolic volumes, which are much higher. So we went for physiological pacing using a left bundle lead. Here is the pacemaker she has. She has an ischemic cardiomyopathy. She has a long stent already, which was patent, done about 10 years back. So the apex is being paced by the right ventricle, and pacing the right ventricle apex is a bad idea because it can lead to cardiomyopathy later on. So this is the left bundle lead, the same patient being placed. You can see right in the septum, and we pierce the septum to go on the left side. And after the pacing, this is the position of the leads. The RV septal lead was capped, RV apical lead was capped, and the LB left bundle pacing was enforced. This is the ECG after the pacing. You see the QRS has completely normalized. The QRS duration has normalized. Next morning, her circumferential strain pattern showed absolutely normal circumferential strain patterns. And she recovered her ejection fraction in a period of 1 month to an ejection fraction of 50% with NT-proBNP falling remarkably. So this is a new modality which can help many patients who are not candidates for CRT because they may have a poor lead in the left ventricle. They may be having a scar on the left ventricle. But this has to be done very properly, and you have to get QRSs like this only to show benefit. This you can't replace CRT at the present moment until we get more randomized trial, but in patients like the one I showed you, and in some CRT failures, this could be another method of treating these patients. And I would close at that, and would invite questions from the participants.
I think in the chat box, there's only one question. I think in the interest of time, I think we'll finish the two cases and then take questions. Ajit, is that all right?
Yeah, I think that's fine. Yeah.
Okay. So we'll ask Dr. Muttaya, who will be presenting a case related to CRT. I fully agree with what Balbir has said. It's a remarkable therapy, but grossly underutilized. And there are several nuances, and we'll have Dr. Muthaiya present one such case why understanding everything regarding CRT matters to a patient. Muthaiya, please.
I hope you can hear me. Okay.
Yeah, loud and clear. Please go ahead.
Okay. So thank you, sir. So I'll be just showing you a case where refractory atrial arrhythmias in a young man with HCM, how it led him in and out of heart failure. So I'll just start. So this man was 36 years old when he first came to us. He presented in NYHA class 3. He had already had a previous admission for heart failure. I'm sorry about the quality of the ECG, but this was his ECG in sinus rhythm at that point in time. We can see a IVCD kind of pattern. QRS was roughly 140 or 150 milliseconds, and features suggestive of biatrial enlargement on the resting ECG. So subsequent to this, this was his echo. I'll just play this for you. So you can see biatrial enlargement. You can see LV septal thickness was roughly 18 to 19 millimeters. And initially at his presentation, the EF was 45%, a restrictive filling pattern with an E by E prime of 23 and a moderate MR. You can see the mitral filling pattern, which was also suggestive of a grade 3 pattern. So initially at this point in time, an MRI was done. MRI showed significant amount of scar in the left ventricle and the intraventricular septum. Intraatrial septum was thickened, and actually we ruled out diagnosis of infiltrative diseases of amyloid and Fabry's in him, even though he was a young male at this point in time. But genetic testing was done, and we confirmed myosin heavy chain mutation in him. So we diagnosed him as a hypertrophic cardiomyopathy. So the problem was whenever he went into atrial flutter, and this goes to that not all atrial kicks are equal. In someone with a stiff heart, especially in someone with hypertrophic cardiomyopathy, the atrial component of the kick is more contributing to their cardiac output, more than the normal of 25 or 30%. And this man, whenever he went into atrial flutter, he would immediately go into cardiogenic shock, requiring inotropic support. And this went on multiple admissions with this kind of heart failure over the next 2 to 3 months. His atrial flutter was refractory to multiple medical therapies and 2 DC cardioversions also. So we went ahead and he underwent radiofrequency ablation for this left atrial flutter. PVI isolation was done, and a roof line was also drawn along with a septal line for the left atrial flutter. But after the ablation, after 1 month, he still had a recurrence of atrial flutter. So at this point, the options available, we discussed with him and the family, and we decided that the best thing for him may be to do a AV junction ablation with a CRTD implantation. This is what was done for him. And following the CRTD implantation, he did improve transiently, but we can't say that his functional class really totally improved. And although we were able to load him with more medications after the CRTD than he was initially tolerating before the implantation. This was his ECG after the CRTD was implanted. We can see a paced and a bi-V paced rhythm. The sensed and paced AV delays were 100 and 130 milliseconds. And actually, he had programmed his sync AV algorithm to be on, which was an algorithm that the device would automatically measure your intrinsic AV delay and shorten it accordingly. But so he had 90% bi-V pacing. So, but the problem was he was not responding. And he continued to be in NYHA class 3. And if we see the complex in V1, we can see that although we see the spikes and the QRS, we're not able to see a great P wave that is seen in the ECG. So he continued to be symptomatic. At this point, we took him to the Echo Lab along with the programmer, the device programmer. And this is the crux of this case, is that you need to optimize the AV filling for each patient. And this is important because in a patient, especially with hypertrophic cardiomyopathy, where he's having a restrictive filling pattern, you need to really optimize the left atrial contribution. So the purpose of AV optimization is 2 things. One is you want to optimize the left atrial contribution to the left ventricular filling, and you want to maximize the time that this patient spends in diastole. So the maximum ENA period. So this was the initial programming of a paced AV delay of 130 milliseconds. And if you can see here, As we increase the paced AV delay from 130 to 150 milliseconds, slowly we are seeing that a stronger A wave is seen here in the contour of the E and the A. At 160, it becomes a little bit better. At 180, you can see definitely make out that the truncated A wave that we saw at 130 is much better. And at 200 milliseconds, we found the best or the optimal AV delay. So we maximized the A component, the left atrial component to the LV filling, and the maximum time of your diastolic filling period was achieved at a paced AV delay of 200 milliseconds. And this is just to show that at each AV delay, we look at the E wave, the A wave, and the diastolic filling period. And there is often a sweet spot for each patient depending on their intrinsic conduction and their filling patterns, where if the problem is if it's too short, you will truncate the A wave and lose the contribution. If it's too long, the E and the A will overlap as shown here. And the other thing that happens is if it's too long, this isovolumetric contraction occurs when the valve is open and you can have diastolic MR also. So this patient we programmed with a paced AV delay of 200 milliseconds, and he did well with the NYHA class 2 on follow-up. And this is just his ECG after optimization. And if you can see, this is his P wave that was almost hidden on the initial ECG. And the ECG before optimization, you can see this is the same V1, no P wave at all. And this is the almost entire left atrial component that we're seeing in the P wave in V1 here. So he did well with, he's in NYHA class 2 on follow-up. So that's the case I had to share with you, I think.
Thank you, Mutaya. I think we'll have the questions as they come in, we'll discuss. We have the next case. Who's presenting? Please go ahead.
Good evening, one and all. Thank you, Dr. Narasimhan, for having me here. So I'll be presenting a short case of heart failure and arrhythmia. This is a young girl, dilated cardiomyopathy, severe LV dysfunction. She was in NYHA class 3-4. So you saw this patient in the periphery, and that is her ECG. This is a right bundle, left excess tachycardia, and you can see there is a 1:1 VA conduction in this case. So when I asked the history, detailed history, she has one more elder sister, absolutely normal. Parents, non-consanguineous marriage, no family history of dilated cardiomyopathy or sudden cardiac death. This girl was seen in the periphery actually. She was in hospital. So when she came, her echo at the presentation, she had a severe LV dysfunction. She was already on propranolol, amiodarone, enalapril, and diuretic for heart failure. And I don't know why, this is a right bundle, left excess tachycardia, but she was going on with a diagnosis of junctional rhythm, accelerated junctional tachycardia. So this is just to demonstrate what it is. What I did was, I gave one carotid massage. So if you give carotid massage, you can nicely see now VA dissociation. Now A is completely dissociated. So this is classical right bundle, left excess, narrow QRS tachycardia, and it's a fascicular VT. So initially being in periphery, she was tried because pressures were initially normal. IV beta lock was tried, amiodarone was tried, lidocaine was tried. So multiple antiarrhythmics were tried, which didn't work. After that, overdrive pacing was attempted in her. With overdrive pacing, she used to revert, and the tachycardia VT used to restart immediately. So it was an incessant tachycardia. And even DC cardioversion, she used to revert, and immediately tachycardia used to restart. So from the periphery, after a month, this child was brought to our center, and to cut the long story short, she was taken up for RFA. And I'm just trying one signal. This is the side, this is a posterior region, left posterior region, where we got a nice early signal with some pre-potential. And you can see this mark shows that the site where we have started the ablation, and the halter shows that as soon as you start the ablation at that site, tachycardia has been terminated. There's a post-termination ECG, and you can see it's a memory T sites, but there is some atrial enlargement. There was a LA enlargement is still there. There's a predominant negative component in lead V1. She was sent back stable, and after a month, I'd like to say thank you to Dr. Kumar. He's a cardiologist in Vizag. He has sent the data. After a month itself, you can see that This ECG, you can see it's a normal sinus rhythm, and the atrial enlargement has gone. The component has gone. You can see P wave is now come down, and the EF has also improved. So she is now, it's been actually 3 years. She is doing well. There is no recurrence of tachycardia, and she is not on any therapy now. So the key points here are, there are small number of heart failure patients with the reversible causes. However severe the LV dysfunction or heart failure may be, but we should search for the reversible causes. And if you do appropriate diagnosis and treatment, it will reverse the LV dysfunction like this child. And especially if there is an arrhythmia-induced cardiomyopathy, we should try to eliminate the arrhythmia, maybe first with drugs. But I think Dr. Dikshit has already shown that sometimes we poison them with drugs. If the drugs are not working, you should go to another thing, that is catheter ablation. And very especially if there is a severe LV dysfunction, and if you feel that LA is humongous or aneurysmal LA, like the previous case Muttaiya has shown, we can do the, we can pace and ablate the AV node so that the patient improves. We can give physiological pacing or CRT. Thank you.
Thank you. Thank you. Thank you, Dr. Daljit. That was a good demonstration of how you can tackle a case of tachycardiomyopathy by elimination of the tachy. I think we have a few questions that can go on. Do we have adequate time?
There are about 3 or 4 questions, and then we can take from the first is from Dr. Shanmugasundaram. I think Sanjay, you can probably take this. Is there a role for AV nodal ablation and a pacemaker in at least in those with persistent AFib?
Yeah, no, I think that's a good question, and there's certainly trial data that offers us some guidance. So within the atrial fibrillation population, the strategy of ablating the AVJ and pacing has been shown to improve both the patient's performance in terms of 6-minute walks, quality of life, and there is also data to support improvement of LV function. There is also now trial data to look at not just ablating and putting a regular pacemaker, but doing CRT therapy, cardiac resynchronization therapy, and that actually shows a better profile of the ventricles than just a regular right ventricular pacing modality. So yes, that is certainly an option. However, the thing to keep in mind is that in the long run, these patients, you are confining them to a strategy of being pacemaker dependent. And depending on what age group they come to you at, and also the growing recognition that just because patients have persistent AF does not mean that the process is not reversible. So the concept of permanent AF is gone these days. So while that is an option, our approach still is to try to restore and maintain sinus rhythm, offer them catheter ablation as the first option, consider repeat ablation because it takes oftentimes more than one attempt to get lasting sinus rhythm in patients with persistent and long-standing persistent AF. And we only reserve AVJ ablation and pacemaker therapy for as our last resort after multiple attempts at catheter ablation.
Dr. Sanjay, I think I had this persistent question of how does AF ablation respond in patients with hypertrophic cardiomyopathy with AF? What are the general results? Well, most of the time, AF is a problem to tackle in these group of patients.
I think that's a very good question. And once again, in limited series experiences, the data is encouraging. So our own experience, we put this together a few years back, offers long-term success rates of about 85%. But what one has to recognize is that it's the single procedure efficacy is often no more than 50%. So these patients, when we see them, we prepare them mentally that they will require more than one ablation attempt. The challenges, of course, are their atria are somewhat dilated. There is some element of hypertrophy even in the atrial musculature. And oftentimes, these patients tend to have non-PV triggers that extend beyond the pulmonary veins. So it's a more extensive ablation approach. But with a second procedure, in the majority of these patients, we've been able to achieve lasting freedom from atrial fibrillation.
I think there is a question about was a right bundle ablation done in this case? Daljit, Dr. Prakash Gaikwad from Maharashtra has asked.
No, fascicular VT, we did not do any right bundle ablation. You can see after the ablation, ECG is absolutely normal in her. So it is a posterior fascicular region. We go, we map wherever you get a very early signal in her, especially activation mapping was performed. So you just ablate at the site where you get a nice early signal. It's on the left side, left posterior septal region. So no right bundle ablation in her.
So Dr. Daljit, that was an excellent case, and I really enjoyed your presentation. A few things in terms of, I found your carotid sinus massage maneuver to be quite remarkable because I would have also thought on the first presentation that this could be PJRT or some other form of AV nodal re-entry. So I think that what you demonstrated there was very nice. In terms of the ablation approach though, I know that you went with activation mapping, but did you do other maneuvers to confirm the re-entrant circuit? And at the end, the ablation endpoint in this case was, I presume, your failure to re-induce tachycardia. But was it a point ablation, or did you use a specific approach to target the fascicular system to modify it?
Usually when we do fascicular VT, sir, we do a transeptal approach, and retrogradely we put a duodeca catheter. So that at the same time we can have a multiple fascicular potential, and we can do the mapping very quickly. And this case was done with, because being a child, this case was done with the Navix. So we had two catheters. Because of the time, I didn't put many things together. I have not shown the activation mapping. But activation mapping, yes, we didn't do entrainment in this case. Entrainment was not done, but at the earlier site, ablation terminated. We usually give ISO, but this child was quite sick when we took her on table. So very dilated heart, severe LV dysfunction. So we did again pacing maneuvers to induce the tachycardia. Nothing came after that. It's been 3 years of follow-up.
No, I mean, this is an excellent outcome. I guess one of the points I was going to make was that when we target these tachycardias, one of the things we try to do is characterize the fascicles as you did. And once you've characterized the fascicle after achieving termination of the tachycardia with point ablation, as you so nicely showed, we tend to create a set of linear lesions to transect the fascicle. Because sometimes these tachycardias can recur due to localized re-entry, not necessarily the full circuit where it goes from the anterior to the posterior, but you can sometimes have re-entry within the fascicle itself.
So Sanjay, we have a lot of experience because in India, this form of VT is very common, and sometimes with tachycardiomyopathy. In fact, my first publication was from All India Institute on a tachycardiomyopathy of a fascicular VT with EF for 20%. The child was referred for a transplant. And that was the first case report of a VT causing tachycardiomyopathy. It's published in PACE. So we don't transect. So what we have learned is that this is a re-entry circuit which is not in the posterior fascicle. It is outside the posterior fascicle. It is not involving the posterior fascicle. So we don't need to divide the posterior fascicle by lines, which is also supported by Nogoma's data from Japan. So we map the circuit and we look at potentials. And I look at potentials very carefully. Both in sinus rhythm, this patient was incessant VT. So the potential, the mid-diastolic potentials are very commonly seen. And these are the areas which we target. And they are away from the posterior fascicle. Transecting the posterior fascicle is not the game here. I think this form of VT is totally different from what you may be seeing in America. It's very special VT to the Asian countries.
Kalvi, there are two questions to you. In the interest of time, why don't you take them up?
Yeah.
Very interesting discussion. Data on CRT in right bundle pattern.
Right. So right bundle pattern, there are some patients who benefit. Most of them don't. But few things one must remember that sometimes right bundle branch block may be a mimicry of a left. It's maybe masquerading left bundle branch block. So how do you decide which right bundle is going to benefit? One of the things is to look at the axis. So left axis deviation is an important criteria. And second is to look at the QRS duration. So if it is more than 150 with axis, which is leftward. Third thing is look at the limb leads. If you have notching on lead 1 and doesn't have an S wave, you have an R wave in lead 1 with notching, it is a masquerading RBP. These are the patients who are likely to benefit. So these are the 3 things which we look for in right bundle branch block patients.
One question that somebody has brought up is, Dr. Balbir, which are the patients post CRT whom you would like to put them on RB? And what is the percentage of patients who are likely to benefit post CRT?
All patients of CRT who have ejection fraction less than 40% will be on RNE as well. As I showed you, there is a synergism between the use of RNE and CRT in patients who have QRS more than 120. So there is no doubt that all these patients will also be on RNE.
Yeah, in fact, there's recent data on patients who are post-CRT who are not on RNE forms, a significant percentage of patients who are actually likely to benefit, who are actually sometimes not really put on RNE. So I think they should also be put on
Right. Sanjay, do you have access to, suppose a patient is not chronic or persistent AFib, not willing for ablation, what drugs do you use as drug therapy? Do you have access to dronedarone? What is your experience with dofetilide? We don't have access to these drugs now.
That's a good question, Narasimhan. So as a group, our practice is to use dofetilide a lot in these patients. And we published a paper just a few years back showing that using dofetilide in these patients, actually a lot of patients, I want to say about 40% of patients who were previously considered long-standing persistent actually had spontaneous conversion to sinus rhythm on dofetilide, which is pretty remarkable, just to think about, somebody who's been given the diagnosis. So that's the drug that we use a lot, but we use it as a bridge to ablation therapy for the most part. And that is the preferred approach for us, something that we are putting together currently in terms of, improving single procedure efficacy of catheter ablation in the persistent, long-standing persistent population. Obviously, one approach is to burn till there's not much atria left, which is kind of going back to the original maze approach, if you would. And in our opinion, that's a little bit of a presumption that, ablation can correct all forms of remodeling, because some of it is surely structural, but a lot of it is just electrical remodeling. So a bridge to ablation in the form of dofetilide for a few weeks tends to correct some of the electrical remodeling. And the hypothesis that we have here is that you can still get similar outcomes with a limited ablation approach targeting the pulmonary veins and only non-PV triggers that you can document during the procedure. You can get single procedure efficacy comparable to more extensive ablation. So that's our approach. Dofetilide is our drug. Dronedarone, we have abandoned completely. After the early data that came out, we never really found it to be efficacious in the population. And then with the data that subsequently came out on the mortality association between that drug with persistent, long-standing persistent patients, the Andromeda study, many of those things. So we have gone away from using Multag completely.
How about, if a person has not responded to sotalol, do you still have a response to dofetilide? There are similar class 3 drugs.
They are, but they are not entirely the same. I think one of the challenges with sotalol is that beyond a certain dose, you get just predominantly the beta blocking effects, right? You lose that. With dofetilide, I guess the 500 microgram BID dose, if your patients are able to tolerate, it's a pure class 3 agent, and you can be guaranteed of that effect. So that's one of the, again, I'm just speculating. I don't have any data to really say that that's the reason, but that's the presumption why one works better than the other.
Sure. Dr. Balbir, since a lot of people have questions on physiological pacing. So today, if you have a patient whose left bundle more than 150 milliseconds, classically requires CRT, now would you prefer to put the left bundle pacing, or you would combine it with CRT also? What is your choice as of today?
So, based on no big randomized trial available, CRT continues to be the first choice. If CRT vein location is bad, if surgical risk is high, we can't do it, or is a CRT non-responder, will an addition of a left bundle lead be thought of, not as the first line with the present data that we have.
So would you be putting left bundle plus LV lead also, or you would stop?
No, I would only put a left ventricle lead, do a good job on the site, QLV ratios, try to get the QRS as narrow as possible, optimize the programming, and not put the left bundle lead unless he's a non-responder or the QRS, even after the CRT is prolonged, he has still dysynchrony, and I'm left with no option. Will I think of adding a left bundle lead later on?
And if it was a patient who would qualify for a defibrillator too? So
It'll
something
be
like
yeah, right. So that is going to be a challenge now. So the DF4 leads, you will have no choice. But the DF1 leads, you still have a choice because you could put one in the RV and one in the LV lead. So with DF4, you cannot do anything. And so you have a CRTD, you have an LV lead, which fails, then put in the left bundle lead and attach it to the LV port.
I think there are 5 minutes left.
Narasimhan, what is your choice?
Yeah, I agree with what Balbir is saying. Whenever say the only reason why I put a left bundle lead is patients who can't afford a CRT, where we think we can get away, but the patient can just afford a dual chamber pacemaker, and he has limited finances and the septum looks attractive. It's a typical LBBB. We have got away with just left bundle capture and narrowing the QRS. But having said that, the preferred mode would be to just go ahead and put the conventional CRT and use something like hot CRT in non-responders. We add exactly like what Balbir said. Ajit, there are two questions from delegates which have not been answered. Both are probably related to atrial fibrillation. What should be how about detecting atrial fibrosis by MRI in predicting success with ablation? Sanjay?
Yeah, no, that's a very good question. I think it goes back to some of the publications that came from the Nasser Marouche group showing the utility of different degrees of fibrosis identified using MRI in those populations. And what that study showed is that there are 3 or 4 different categories of fibrosis that can be identified in the atria, and ablation success, at least in that series, was predicated on it. So yes, that is certainly one way to approach it. The challenges are that MRI's ability to truly identify fibrosis in the atria, which is a very thin-walled chamber where the resolution of the MRI may not consistently be as good. So that is a problem. The other problem is that the software and the settings that were used to characterize MRI-related fibrosis in that particular study, that has not been reproduced by other centers. So we participated in that study, and the protocol involved doing the MRI, sending the results over to Utah, then they would analyze it and send us back the information. And when our own radiologists tried to replicate it, we were not able to mimic that. So there is still some challenges on the reproducibility of the data that was published in that series. So at this point in time, as a strategy for ablation, I don't think it's being used. There is another study that's currently ongoing by the same group where they are comparing standard AF ablation to doing PVI plus targeting of those areas. The data on that is still, we are waiting on that.
2 points. That's an interesting point. I would just like to tell you what we saw with MRI and AF in rheumatic heart disease. We found most of the patients with AF and rheumatic heart disease had significant LGE on MRI. And I think that's probably the reason why AF ablation in rheumatic heart disease is not going to be a success. And the next point is that the trial which you said, I think has just come out recently about a couple of weeks back, 2 weeks back, and it is surprisingly has not shown much of a difference between MRI-based ablation versus otherwise.
Correct.
It's an important question again from Dr. Prasad from Maharashtra. This is very pertinent in daily practice. What should be the drug of choice for rhythm control in patients with AFib who are euthyroid or hypothyroid?
So I think what you said, Narasimhan, was that dofetilide is not available.
Not available.
Not a okay.
So I would say that probably sotalol or amiodarone, right? You said the patient was euthyroid.
That's right.
So for us, actually, amiodarone is the drug of last choice, just because of the reasons that we all share, concerns about its long-term use and cumulative toxicity. And then, of course, patient age factors into that. So I would say that sotalol would be the first choice. And then if that fails, amiodarone. But again, I just want to make the case for catheter ablation for AF. That's obviously underutilized world over. I'm sure it's underutilized in India, and maybe something to consider early in the disease process.
We tend to use flecainide quite often for rheumatic atrial fibrillation with very good results. I don't know whether Balbir or Ajit, others may have some. So if the patient has predominant rheumatic mitral valve disease, the LV is actually unloaded in mitral stenosis. So the contraindication from ventricular proarrhythmia is very limited, and therefore it makes it an attractive choice for patients with rheumatic atrial fibrillation with mitral stenosis or mitral valve disease. And there's one, is CRT or his bundle pacing comparable? Balbir?
So, as I said, there is no data to support that they're comparable. At the present moment of time, his bundle pacing will be left for patients who are failures to CRT, whether you can't put the lead or the lead was there but not in the right place, or they did not respond. At the moment, you can't choose his bundle pacing as the first choice for a patient who has a bundle branch block and LV dysfunction.
I think we can go on and on. There seems to be a lot of questions coming in. Some of them, I think we'll take it later and post them in the YouTube. In the interest of time, I think we need to wind up. I would like to thank all the speakers, Sanjay especially for taking some time off and clarifying a lot of queries regarding atrial fibrillation and heart failure. Balbir for the excellent presentation on CRT, and both my colleagues Daljit and Mutaya for very illustrative cases. And Dr. Harikrishna, can we post the answers separately on the YouTube, because the questions keep coming in?
Yes, we can. The session is live and people start posting tomorrow. We'll keep it for a week and we'll post all the questions and answers on the YouTube. In our website also we will keep.
Okay. In which case I would like to close and hand over the thing to Dr. Hari and Dr. Chopra. Thank you very much for this wonderful opportunity and to interact with my friends. Thank you very much, Sanjay, Balbir, and I'll hand over the mic to Hari and Dr. Chopra.
Thank you very much. I think those who have attended should have really enjoyed the talks and the cases and the discussion. So thanks everyone, and Dr. Balbir, Dr. Sanjay, Dr. Ajit and Dr. Narasimhan for coordinating, and the two beautiful cases by Diljit and Mutaya. Thank you so much. Next month we will have the seminar on first week of January. It will be on cardio-renal syndrome. So please do attend and join us. Thank you so much. Good night.
Thank you very much. Thank you, Sanjay.
Thank you. See you guys. Yep.
Bye.
Bye.
Thank you, sir. So I'm ending the meeting now. Thank you.